Today's topic is on periodontal abscess. Learning outcomes are analyze the proposed 2017 classification of periodontal abscess, discuss the pathophysiology of periodontal abscess, differentiate between the clinical features of periodontal abscess and periapical abscess, probe into the various treatment techniques for treating periodontal abscess, discuss periodontal abscess in non-periodontitis patients. So, periodontal abscess is classified under the periodontitis and other conditions affecting the periodontium according to 2017 classification. As the other conditions can be the cause for periodontal abscess, so it is included under other conditions affecting the periodontium in 2017 classification. Coming to the definition, what is a periodontal abscess? It is a localized purulent inflammation in the periodontal tissues. In more details, we can tell that it is a localized collection of pus communicating with the oral cavity through the gingival sulcus or other periodontal sites and not arising from the tooth bulb. It is also known as lateral abscess or parietal abscess as it is situated in the lateral aspect of the root. So it has been classified according to various conditions. Like according to location, it has been classified into two. That is, first one is abscess in the supporting periodontal tissues along the lateral aspect of the root. With this condition, a sinus generally occurs in the bone that extends laterally from the abscess to the external surface. Second one, when the abscess in the soft tissue wall of a deep periodontal pocket. So according to the location, it has been classified into two. Coming to the onset or course of lesion, it can be acute periodontal abscess or chronic periodontal abscess that is associated with chronic periodontitis or periodontal abscesses occurring in systemically compromised patients commonly can be seen in diabetes patients. According to the number of abscesses, it has been classified into single and multiple. Single due to local factors that contribute to the closure of pocket. So it will be accompanied with a single abscess or one site abscess, whereas multiple it is mostly reported in diabetes mellitus patients and medically compromised patients. So in that you will be seeing multiple number of abscesses. You can see in this picture that this patient is having several number of abscesses. Coming to the etiology, either it can be due to periodontitis, that is periodontitis related abscess, or to sites without prior existence of periodontitis, that is non-periodontitis related abscesses. So coming to the periodontitis related abscess, the reasons can be due to tortuous pockets with root morphological peculiarities. So you can see that if it's tortuous pockets, that is if it's a complex pocket due to the root morphological peculiarities, the opening will be very minimal. So it can lead to the abscess formation. The second one is marginal closure of pocket which leads to an extension into the surrounding tissues. So this inflammation can lead to the surrounding tissues due to the pressure of separation inside the closed pocket. That can be the next reason and which occurs at different stages also, that is as an exacerbation of an untreated periodontitis, refractory periodontitis or during periodontal maintenance also for the due to the improper removal of local factors or due to the increased inflammatory process which can lead to the abscess formation, and also it can be due to fibrin secretion as a part of healing which leads to localized accumulation of pus which may favor the closure of gingival margin to the tooth surface. So this more amount of fibrin production can lead to the closure of the gingival margin, so which lead to the localized accumulation of pus. So then there will be changes in the composition of microflora from gram positive to gram negative uh, anaerobes. So bacterial virulence or in-host defenses could also make the pocket lumen insufficient to drain. And also treatment with systemic antibiotics without subgingival debridement also one of the reasons. Then incomplete removal of calculus or inadequate scaling and might get dislodged into the soft tissues. So these are the reasons, some of the reasons for periodontitis related. So coming to the term periodontitis related abscess, can be various reasons for the cause of non-periodontitis related abscess. First one is the impaction of foreign bodies. So it can be either flows, brush or fish borne. So which leads to gingival abscess or oral hygiene abscesses, and also lateral perforation which happens due to the endodontic therapy or root canal treatments. which traumatizes the periodontium and which leads to non-periodontitis related abscess. And also like local factors affecting the morphology of roots such as seminal tears, external root resorption. So that can be also one of the reasons for non-periodontitis related abscess. Other causes can be diabetes, usually multiple abscesses are seen, or any forcing of calculus into tissues during instrumentation. Then prolonged systemic antibiotic therapy for the non-oral causes. Then trauma from occlusion. So what are the symptoms for this periodontal abscess? So definitely pain will be there, which will be more severe in case of palatal abscesses compared to the other areas. And avoid swelling on the gums, sometimes extending into the alveolar mucosa. The other symptom, and pain while biting may be absent, but pus discharge or bleeding can be seen. Itching sensation in the gums and tooth feels high on biting. Coming to the signs, avoid swelling on the gingiva along the lateral surface of the root involving the marginal and attached gingiva. So the gingiva usually appears inflamed. With this, avoid swelling. Tenderness on palpation present, tenderness on lateral percussion, not very prominent. Tooth mobility is evident, periodontal pocket will be present. Pus discharge through the pocket or through a sinus if present. Then presence of subgingival calculus. Coming to the formation, periodontal abscess formation may occur in the following ways. First one, that is the lateral extension of inflammation from the inner surface of the periodontal pocket into the connective tissue of the pocket wall. The formation of abscess results when the drainage into pocket space is impaired. So when the inflammation, if it spreads from pocket to the connective tissue, if it is not drained properly through the pocket, then the resultant abscess will get formed. The next one is that the extension of inflammation from the periodontal pocket deep into the supporting periodontal tissues and the localization of the suppurative inflammatory process along the lateral aspect of the root. So, if it is accumulated along the lateral aspect of the root, it forms periodontal abscess. Then the other cause is that that is the formation in a pocket with a tortuous course around the root. So if it is a complex type of pocket, so the drainage won't be that much proper. So in that case, a periodontal abscess may form in the cul-de-sac. So it will get trapped inside, the deep end of which is shut off from the surface. Then the other way of formation is that incomplete removal of calculus during treatment of a periodontal pocket. So then gingival wall gets shrinks after the initial scaling. So thereby occluding the periodontal pocket orifice. So what happens? This periodontal abscess occurs in the sealed off portion of the pocket. That is the other reason way of formation. The last one is that after trauma to the tooth or with perforation of the lateral root in case of endodontic therapy, that is usually with the non-periodontitis related abscess. So in these situations, a periodontal abscess may occur in the absence of periodontal disease. Coming to the pathogenesis, microscopically, abscess is a localized accumulation of viable and non-viable PMNS within the periodontal pocket wall. So when there is inflammatory component, there will be more amount of PMNS. So when there is more amount of PMNS, which they will liberate enzymes, so that has the ability to digest the cells and other tissue structures. So thereby, which will form the liquid product known as pus. So which constitutes the center of the abscess. So an acute inflammatory reaction surrounds the pulmonary area and the overlying epithelium exhibits intracellular and extracellular edema and the invasion of leukocytes. So the localized acute abscess becomes a chronic abscess when this pulmonary content drains through a fistula into the outer gingival surface or into the periodontal pocket. So the bacterial invasion of tissues has been reported in abscesses. The invading organisms were identified as gram-negative cocci, diplococci, fusiforms and spirochetes, and also invasive fungi were also found. So it has been interpreted as being opportunistic invaders. So microorganisms that colonize the periodontal abscess have been reported to be primarily gram-negative and anaerobic rods. So coming to the differential diagnosis, so various abscesses are there: periapical abscess, gingival abscess, periodontal abscess, and pericoronal abscess. Periapical abscess it forms at the root apex, and gingival abscess it forms in the space between the gingiva and tooth. And periodontal abscess it forms in a periodontal pocket, and pericoronal abscess it forms around impacted or partially erupted tooth. So periodontal abscess, how it is different from periapical abscess? So periodontal abscess, you can see that the dull, constant, less severe, and it is localized, and patient usually can locate the offending tooth. Whereas periapical abscess, this pain is very severe, throbbing, and lasts for long, deep, unable to locate the offending tooth, and it will be more severe than the periodontal abscess. Periodontal abscess, the radiographic feature is that lateral radiolucency can be seen, whereas periapical abscess it is apical radiolucency. And periodontal abscess it is more associated with pre-existing periodontal pockets. Caries can be, or both can be. It is not associated with caries. It is more with the periodontal periodontitis. So periodontal pockets and caries. Okay. And periapical abscess, it is associated only with the deep restoration, caries or tooth wear. Periodontal abscess, the pulp test will be vital. Periapical abscess, non-vital. Periodontal abscess is swelling generalized and localized around the involved tooth and gingival margin, seldom with the fistular tract, whereas periapical abscess swelling or localized often with fistular tract opening in the apical area. So coming to the gingival abscess, so periodontal abscess which involves the supporting periodontal structure, whereas gingival abscess it is only confined to the marginal and interdental gingiva. So which often periodontal abscess often occurs in the course of chronic destructive periodontitis, whereas gingival abscess occurs in previously disease-free areas. Periodontal abscess, X-ray bone loss present, so that is bone loss can be seen, whereas gingival abscess, this bone loss cannot be seen because acute inflammatory response due to the forcing or embedding of the foreign material into the gingiva. So periodontal abscess, pocket present, gingival abscess, no pockets. So coming to the diagnosis, so how we can diagnose the abscess, whether it's periodontal, periapical, gingival or pericoronal. So more than that, in periodontal abscess, the radiolucency will be along the lateral aspect of the root. And usually you can see the vertical type of bone loss, and this radiograph is required to rule out any periapical involvement. If there can be periapical involvement also in case of periodontitis case. The source of infection may be tracked by inserting a GP point. You can see that clinically you can insert the GP point to track the source of infection up to the base of the pocket or through the sinus present. You can see after that you can take a radiograph and you can say point out the abscess area. So coming to the management, it has been classified into initial phase and definitive phase. So this will come under the emergency phase, the periodontal abscess. So first thing, due to the acute symptoms. So in initial phase, we have to reduce the acute symptoms, and definitive phase, and after this acute symptoms get subsided, we will go to the advanced treatment of periodontics. So coming to the initial phase, that comes with drainage of the abscess. Any abscess, if there is a drainage, is the first initial phase for removing the acute symptoms. Establish drainage preferably through the pocket if it is draining through the pocket. In case of large abscesses, if it is not getting drained through the pocket, then external incision and drainage might be required. So that is buttonhole approach, that is incision and drainage. So that is the open approach. So when it is draining through the pocket, it is closed approach, and if it is draining through the by incision, then it is called open. So that is the intra-pocket drainage, closed approach. Pocket wall distended by a periodontal probe or the thin tip of an ultrasonic scaler, which helps in evacuation of pus. So which remove deposits on the root surface by scaling and root planing. So followed by curettage of the pocket wall. Then sequential irrigation with saline and chlorhexidine or betadine. Then you have to grind of the tooth to reduce the occlusal contact. So this is based on the intra-pocket drainage closed approach. So any secondary pulpal involvement should be ruled out at the first visit itself. So in periodontal abscesses with periapical involvement, drainage through root canal can also be done. So after the treatment, coming to the follow-up medications and the patient instructions. So analgesics can be prescribed. Antibiotics is clearly indicated for medically compromised patients, example diabetes, abscesses with systemic manifestations, that is tender lymphadenopathy, fever, etc. So whenever antibiotics are prescribed, it is better to do the abscess drainage during the course. And okay, under patient instructions, warm saline rinses can be given every hour. Follow up 24 to 48 hours to monitor the response. If no improvement is seen, you can suspect of endodontic involvement also. Review after 1 week for definitive. In any case, antibiotics should not be used as a sole treatment. Remember, antibiotics can only suppress the signs of periodontal diseases. They can never cure. Coming to the definitive treatment, once acute symptoms have subsided, so the underlying periodontal problem should be treated as soon as possible to prevent the recurrence. So otherwise, if the underlying periodontal problem is not getting treated, again the periodontal abscess can occur. So multiple episodes of periodontal abscess which results in rapid bone loss, gingival recession, pathologic migration, endodontic involvement, and ultimately tooth loss. So, on a positive side, surgical treatment of acutely abscessed areas generally show more favorable results. Also, the occurrence of an abscess is a big motivation for the patient to undergo treatment. So, an abscess tooth may be indicated for extraction if it is excessively mobile, that is grade 3 mobile with questionable prognosis. So, mobility should only be evaluated only after the acute stage has subsided. If there is any history of multiple periodontal abscess in relation to the same tooth, then it is indicated for extraction. Then, if the endodontic treatment is not possible with that tooth, then it has to be extracted. Then, poor restorability. As we conclude, the periodontal abscess is the third most frequent dental emergency. The periodontal abscess is a frequent periodontal condition in which periodontal tissues may be rapidly destroyed. Its importance is based on the possible need of urgent care, the affectation of tooth prognosis, and the possibility of infection spreading. So, thank you for now.